Welcome, everyone. My name's DJ Wells with the Mensah Research Institute and Mensah Medical, and you've tuned into our weekly conversation about coping with COVID, our series of webinars and conversations where we talk about ways that we're managing and navigating this pandemic that we've been dealing with for the past several weeks. For those of you that tuned in last week looking for our weekly conversation, we had a last minute 11th hour cancellation. We apologize for that, but we're glad to be with you again this week. And this week, what we hope to do is continue the conversation that we started 2 weeks ago. Those of you that were with us 2 weeks ago, you'll recall we had Dr. Judy Bowman with us, and Dr. Bowman and Dr. Mensah were just taking all of your questions as they related to the COVID-19 pandemic and all of the other things that are going on around the pandemic. Well, since those 2 weeks, in that 2 weeks since we were last with you, things have changed just a little bit. We've had several states, in fact, all the states that have started to open up and lift some of the social distancing restrictions and some of the business restrictions. And we've also had a few things going on the social unrest front that have brought a lot of people out into the streets and a lot more contact than we were probably anticipating coming out of these social distancing restrictions. So a lot to talk about today. Several of you have sent in some questions. Those of you that want to send in questions today during our conversation, use the Q&A tab there on your screen. We'll get to as many questions as we can today in the time that we have. Dr. Mensah, thank you for joining us again. Let's talk a little bit about this new normal that seems to be sweeping the nation here.
Thank you, Mr. Wells. Whenever I hear that term, I almost wince because we don't know what normal is yet. We've seen a tremendous number of pandemic and epidemic movies out there. What is scary is that as I go back to watch these movies, how real and accurate they've turned out to be, outside of zombies coming out and things like that. The pace, the direction, the fear, the protestations, the individuals literally coming out against regulations and coming out in force and doing whatever it is they feel like doing. In some cases, those are things we've already seen. It's been rehearsed, it's been practiced, but it's real. So the challenges are also real here. And we don't want to minimize, and that's why we're doing this series to kind of say, hey, let's keep some grounded perspectives here, okay? The truth is there, but we're still waiting for what that normal looks like. It might even take up to another 6 to 8 months before we see real normal, whatever that means.
I absolutely agree with you. You're right. This idea of new normal. Who knows what normal will be, because the world truly has changed, given the fact that we've gone through these changes, the pandemic first, and now the social unrest that is causing change as well. Yeah. Speaking of that social unrest, are you concerned? Let's kind of put these two topics together. How concerned are you now that we've very quickly come out of social distancing and now people are congregating all the time for these protests and these demonstrations? Are you afraid that we might see another wave of infections coming in the next week or two?
We're very concerned about that. And when we say we, this time I don't mean the regal we, I mean we as physicians, we in the healthcare industry are extremely concerned. First of all, before this wave of social interaction ever occurred, we were already anticipating a second peak within the first wave, okay? While understanding that as the summer season goes and the winter season comes, somewhere between late October, early November, and next February, March, we would be anticipating yet another wave, okay? Well, underlying all that, we have now the rural communities that are starting to become infected, or rather to show these problems. We anticipate that getting worse. Now, what's different is that folks, you folks in New York, Chicago, Atlanta, LA, major cities across the United States, you're used to being able to say, gosh, I tried to get into the hospital and I was told no, or I couldn't get that test done. Imagine areas where the closest hospital is more than 20 miles away. I have worked in those small towns, okay? There are places where the closest hospital may not have any more than 4 ICU beds and still have a population greater than, a few thousand. So even if a fraction of those individuals got COVID and they went to the hospital, they would have already overwhelmed the hospital's capacity. It's a very serious thing that's starting to happen, and we're only seeing that now beginning in the rural communities. Now, let's superimpose upon that our new social, cultural protestations that are going around. We don't minimize them, please understand this. It's not a political commentary. But with all these folks coming out and voicing their opinions, voicing their hearts, voicing their frustrations, we've had a whole lot of people in close contact. Tremendous numbers, more than would naturally happen in case of a peaceful environment in general. So we've had exposures, there's no question. We've seen rates go up in certain towns and countries, and counties in excess of 500 new cases overnight. Okay, this is happening. We anticipate that there are going to be more challenges. We're prayerful that it doesn't, but there's a difference. Most of us believe in the medical field, we're going to see a huge increase once again.
So when we were last together a couple of weeks ago, and actually over the course of several of our conversations, we've had a lot of conversation about, all right, we know that a lot of people are going to get this. There's really no way that we can avoid it in some capacity, or certainly minimal ways that we can avoid a large portion of the population getting it. And so a lot of our conversation has been around how to make yourself better prepared to handle the virus if you become infected, building up your immune system and that type of thing. And so some of the questions that that have come in over the course of the last couple of weeks, and some of the questions that we didn't get to last time, speak to some of the things that you have suggested during these several webinar broadcasts that we've done so far. Things like vitamin C, vitamin D. Can you kind of give us a refresher on some of those nutrients that we should be including, and then we'll get to some of the more specific questions that folks have asked as well.
Certainly. We talk about key elements, and folks out there, I want you to understand, we're not talking about vitamin health. We're not talking about nutrition, although they're kind of related. We're actually talking about molecular analysis, molecular understanding, and molecular treatment. Now, you call a vitamin whatever you want to call it. Vitamin C is ascorbic acid, okay? And as an entity known as ascorbic acid, it is extremely vital in not only almost every single function your body can possibly imagine, but in terms of immune support, it is of the utmost importance. What's also very key is that it is by way of inhibiting many of the mechanisms that vitamin C is involved in, by which the COVID virus actually works. So let's just say COVID breaks vitamin C regulated treatments, movements, if you will, in the system, functions in the system. So what do you do to repair it? Give what's been broken, the vitamin C. But you've got to give the right dosages. Folks, I always say this is like being a human mechanic, okay? So those of you who like cars, even if you don't know anything about cars, if your car's got a problem, you take it to the fix-it shop. It's called a fix-it shop for a reason. You want them to fix the original problem, right? So if you don't have oil, you want oil in your car. If you've got spark plugs that aren't working, you want new spark plugs. If your hoses are broken within the engine, you replace the hoses. You don't put duct tape around them and pray that the car is going to work. But that's what we do in medicine all the time. We've gotten so used to using duct tape to try to work over here without addressing the core problem over here and fixing it. Molecular agents like vitamin C, like zinc, like melatonin directly affect the actual mechanistic problems created by the COVID entity, the COVID virus. That's why we talk about this so heavily. It's not about simply getting antioxidants and anti-inflammatory agents on board. These are the pieces that have been destroyed, missing, or in small quantities, okay? So we look at, once again, vitamin C, we look at zinc, we look at melatonin, we give an honorable shout out to vitamin D, but folks, these are the keys. There are lots of other agents out there that can help with inflammation that are pretty decent, but these are the main elements that you need to have in your arsenal. And my top three, of course, again, vitamin C, zinc, and melatonin.
Now, you spoke a lot actually about vitamin D last time and higher dosages of vitamin D. And we did get a couple of questions regarding that. And of course, there are conditions where you can have a little bit too much vitamin D in your system. And so folks were asking about, how does one know if you're taking too much vitamin D if you're trying to boost your immune health?
Well, I'll share with you the clinical side. Most people really don't know what too much vitamin D is. And for the most part, we see a lot of people taking anywhere between 2,000 and 10,000 international units of vitamin D in a given day. And you know what? That's fine. One of the researchers that I encountered, he and I were having a very interesting discussion at a conference. He's a PhD. His thesis was on vitamin D. And we were talking about this concept of toxicity. And this gentleman was very nice. And he said, well, Dr. Mensah, what kind of dosing do you use on average? And I said, well, for our patients who are in need, we tend to use somewhere around 5,000 international units of vitamin D. And this doctor said, oh, please. Listen, when I did my thesis, we were talking about 50,000 international units of vitamin D. Now, folks, do not go out and get 50,000 international units of vitamin D. This is more about we are seeing that toxic dosages are at an almost unfathomable level, according to many researchers. So we're pretty good, we're pretty comfortable around 5,000 to 10,000 international units. So I wouldn't worry too much about that. For the most part, we're good. Most people will not really ever get to 50,000 international units at all, or even close for that matter.
And what about vitamin C? And you've mentioned vitamin C, and you just mentioned it a couple of minutes ago as one of your top threes. What are we looking at in terms of dosage there? How much more should we be getting? I think you and I were talking before, and we kind of made the analogy of plugging yourself into an orange. And being able to walk around with that constant source of vitamin C. What makes sense?
Well, in our patient pool, for example, just in general, this is before COVID, we tended to have somewhere around 2,000 milligrams of vitamin C per day. And now we've got a wonderful group of antioxidants that most of our patients are on in general. So they're doing okay with regard to that. So we don't have to have a whole lot more, relatively speaking, in terms of vitamin C. But when we're looking at this age of COVID and we're looking at boosting immune support, we're pretty much recommending that the average adult who doesn't have any other real challenges as far as we know, be on at least 5,000 to 6,000 milligrams of vitamin C per day. Now, if you end up, feeling sick or whatever have you, and you think that maybe you got COVID, that goes to 10,000 milligrams of vitamin C. I should say ascorbic acid, better form, ascorbic acid per day. So that's 5 in the morning, 5 in the evening, or 3 here, 3 there, and then 3.5 milligrams during the course of the day, divided in divided dosages, whatever works for you. And I know what somebody out there is thinking. Somebody's saying, well, what about the diarrhea that happens? Well, listen, folks, if you get diarrhea from ascorbic acid, number one, there's a problem in your GI tract. That is not a normal response. It's your body telling you there's a problem. Now, so that needs to be investigated. But secondarily, let me share with you something else that's very interesting. If you are really sick like that, your body compensates because it needs the vitamin C. And so you don't get those symptoms associated with the diarrhea and any other challenges that might come from high dosages of vitamin C or higher dosages of vitamin C. Your body kind of says, hey, hold back everything. We need this. Let's welcome it and let's leave everything else alone. So we're pretty much good in that reign. Now, if you're in the ICU, that's a whole nother story. Then there's IV vitamin C. The other ones we were talking about were oral dosages. And that's a whole nother issue altogether, and we'll talk about that separately. But for the average person out there right now, our recommendation is about 5,000 to 6,000 milligrams of vitamin C, just in general around this next 3-month period. And then if you feel like you're getting those symptoms of COVID, then that should increase to 10,000.
And what about our other two in your trifecta, the zinc and the melatonin that you've mentioned earlier in this conversation?
Absolutely. I'll make a long, verbose story very short. Zinc for the next 3 months should be anywhere between 80 to 100 milligrams. If you're one of our patients, you're typically on a very strong dosage of zinc picolinate form we like to use. At that point, you pretty much go to 100 milligrams for the next 3 months. If you're not one of our patients, you really should probably start to build up slowly, okay? And start with maybe more around, say, 30 milligrams to 50 milligrams in the first week, then increase that to about 80 milligrams in week number 2, and then get up to about 100 milligrams and stay there the next 3 months or so, okay?
And melatonin? And I know that with melatonin, the couple of times I've taken it, it makes me awfully sleepy. So that's one that we should be taking at night anyway.
Absolutely. Melatonin should be taken at night. And folks, most of us are already taking too much melatonin. We're seeing it in 3 milligrams and 5 milligrams. And some folks are even taking 10 milligrams. Okay. But from a biophysiological perspective, the latest research is showing that at 0.5 milligrams, in other words, half of a milligram to 1 milligram of melatonin at night is what your typical adult needs in order to help support that immune system optimally and to work against what the COVID is doing. So you don't need much. As I say, a little bit will do you.
Now, we've seen over the course of this entire pandemic, and some of our leaders have talked about the various treatments and cures and other things that they have promoted for COVID. Certainly, we've heard a lot about the drug hydroxychloroquine. What are your thoughts about hydroxychloroquine and some of the others that are starting to come on the market now as potential cures or certainly treatments for COVID-19?
Okay, this particular drug was a useful entity in malaria treatment. And people ask, well, why are we talking about malaria in the same voice as we're talking about, a virus? Well, both of these entities kind of work in a similar fashion as far as infecting red blood cells. That's the key process, infecting the red blood cells. And hydroxychloroquine was a really decent idea in that it could kind of help shift that destruction away by affecting or decreasing the infectivity of the red blood cells by either the malaria parasite or the COVID virus. Now, we've talked to a lot of doctors all over the world on this topic, and it's very interesting. Everyone's got their perspective, okay? So one very, very well-established, brilliant physician that we spoke to said that, he thought the hydroxychloroquine, when you're talking about the side effect potential, and usually the side effect potential involves cardiac issues, arrhythmias, and potential death. One cardiologist said, he's been working with that drug for a very long time, and he's yet to see a case of morbidity associated or mortality associated with that particular drug. Other doctors and studies have shown that there's an increased risk of such. And there are doctors who simply say, well, listen, the potential side effect here of hydroxychloroquine may be death, but a real side effect of COVID is death. And so for them, they're willing to do that. Now, what do we say? Okay. Again, these are drugs. We're not looking at this from a drug treatment level. We're looking at this from a molecular level. So from our perspective, it's not worth the risk, because when we look at molecular agents, they don't cause death. That's not a side effect. That's not even a side potential. So in our world, focusing more so on the actual mechanism of what's going on and how to fix it, how to shift this entire creature and how it works and how the body responds to it is what we want to focus on. As a physician in general, and not a molecular specialist, I would still say I don't think hydroxychloroquine, I personally don't think hydroxychloroquine is worth the risk. I think that, first of all, for what it does, which unfortunately, we're only talking about a decrease of infectivity and symptoms for a short period of time here. It's not powerful enough to suggest it's worth the risk. That's how we at Mensah Medical look at this. And again, every doctor's got their perspective on this, but let's look at this from this perspective. You can either have a slam dunk where there's no risk and have real gains, or you can have, well, maybe an attempt at a shot, basketball analogies here, attempt at a shot where you're probably going to miss the rim anyway. You may not even hit the backboard, but you're going to go ahead and shoot, okay? In other words, no real positive gains that are worthwhile, but you still got that huge risk. So in our world, hydroxychloroquine is not the case. Now, many of you know that maybe we're not, quite so hype on drugs. Please understand, as physicians, we use drugs that we feel we need to. It's not about an all or none situation. It's about who the patient is in any given case that dictates what we do. We, like anyone else, we're looking forward to, yes, when that appropriate vaccine comes out. That is a drug. And yes, you want to get that vaccine, especially if you're in certain cases. But we have to make sure the vaccine is, first of all, that it works, it's stable, the side effects are not going to be worse than the actual cause. We don't get people turning to zombies later on in life, like all the TV movies have been showing us. It's got to be the right vaccine. But when it comes out, that will be a very powerful tool. Now, there are antiviral medications that have shown great promise, and they too will be developed, and they too may be good adjunctive creatures. But then we get to sit back at that point and ask a very interesting question. Do we want something that is simply an antiviral, or do we want to actually fix the problem in the system? And we may find that it may be a combination of the two approaches that we actually use at that particular point in time. But for now, we don't have any of those drugs that are approved. We don't have any antibiotics or any antivirals or anything else that truly, unequivocally do what it is that we're hoping they'll do, which is to fix the problem or prevent or to cure. When we've got that, then I think we can go to that conversation. But for right now, we don't have it. So let's get back to fixing the problem in the first place, fixing the mechanisms that are being distorted.
You started to touch on this issue of vaccines, and we've got a couple of questions from some of our viewers asking specifically about vaccines and our feelings or the Mensah Medical feeling about vaccines just in general. Certainly, we are hearing this conversation about what's going to happen when we get the new vaccine, but because we're rushing to get this vaccine produced, are there concerns about testing, about the vaccines causing problems that might not be anticipated because we're rushing to get this developed? Injury as a result of these new and untested, or certainly not widely tested vaccines that are being rushed to market. What are your thoughts on that?
I think rushed is a very interesting term and involves some qualification here. No drug at this stage, at a pandemic stage, I shouldn't say no drug, but the idea is that a drug does not get through an appropriate screening process, an appropriate evaluation process, and an appropriate efficacy process, okay? Because people getting vaccines and not getting better doesn't do the company that produced the vaccines any good. It causes them severe ill repute. It may even produce lawsuits. So the organizations that are also involved in scrutinizing these drugs and testing them in the trials, they're also very good. This is not their first rodeo, shall we say. They're going to make sure this is appropriate. I think part of the problem is that we keep talking about an expedited schedule as a population, as media, as politics, as whatever may happen. But the folks who are actually the scientists doing this are not. People are still saying, look, we're more than 9 months to a year away from a reasonable vaccine in terms of everything that needs to be done properly, okay? So we're not really talking about something that's going to come out next week, next month, or that'll be a wonderful Christmas present for everybody. No, that's not going to be happening. And if it does, I'd be very skeptical, okay? But we're talking now, okay, maybe in March, April, May, June, whatever have you, at that particular point in time of 2021, we might be seeing some really appropriate potential trials going on, okay? But I don't think rush from the perspective of getting something out there that may harm the population is what it is that our wonderful agencies are doing. There are standards and there are protocols. And despite what anyone else says, for the most part, scientists are very cautious and they want to make sure it's done right because they know lives are on the line, namely not only their families, but everyone else's as well. They take this very seriously. So I think when it happens, there'll probably be a good enough version to warrant the utility of. And then there may be improved versions over the course of time. But I think it'll be happening in the right time in the right place.
Now, there's certainly, as we're all aware, an anti-vaccine movement out there, folks that are against vaccinations just in general. And there are conversations about herd immunity and allowing for people to get sick because they'll develop the antibodies and that type of thing. What are your thoughts about that as it relates specifically to this COVID-19 pandemic?
Well, first of all, let's remember that this is not that type of creature. This is a Frankenstein virus. It's got elements of so many viruses out there that you don't want to play that game of Russian roulette. And number two, it is a flu-like virus. Nobody sits around and has flu parties. When somebody gets sick with the flu, you don't have neighbors and family and cousins coming over to the house to catch that flu because there's several different strains of the flu. This concept of herd immunity is questionable to me personally, okay? I'm not going to speak to other people out there. To me personally, it doesn't make any sense as a scientist to have a virus considered something where herd immunity happens. Viruses change their coats. They change all the time. This one had 30 different mutations within the first few months. So if you had immunity to version number 1, it doesn't mean you're going to have immunity to version number 20. Same virus, different characteristics. So you don't want to play that game. The other reason is that the very people that you infect on purpose will go home to somebody who doesn't know they've got a susceptibility and could literally kill that person. So you don't want to play that game. Mom, dad, sisters, brothers, whomever, you never know what's really underlying those genes right now. We're not at that level. So it's safer to have real protection on an individual level than to try to play that game of herd mentality. It does not work. It doesn't even make sense to me. It's not logical. Okay. This is not the measles. This is not the mumps. This is not the chicken pox. If we were talking about the chicken pox, I'd say, sure, go ahead and gather all you want. No big deal. We used to do that back in the 70s, not me personally. I was way too young back then, but we heard about adults who would throw parties and get kids together because you could do that with the chicken pox, okay? You can't do that with this virus. This virus can kill. So we don't want to play that game. So when it comes to a vaccine, my particular thought is that when a really good, solid vaccine comes out, folks, you get it. You get it. because it can save you a lot of time, a lot of trouble, protection, not worrying about your kids and things along those lines for the most part, as far as we know. With the right vaccine, that's the best way to go, unless you're already very well protected and have a fabulous immune system. But even then, it may never really hurt. Okay, so we'll have to weigh those cost-benefit analysis when the right vaccine comes out at that time.
So, and we started to touch on this a little bit earlier today, the idea that that this virus, because it's so infectious, that it's likely that a lot of people are going to get it, whether they're trying to get it or not, even
Mm-hmm.
with social distancing. And then, of course, now we've got the protests, so more and more people are coming in contact with each other. And so, we kind of struggle with or wrestle with this notion of avoiding the virus versus being healthy enough to survive the virus. But at some point, many of us may contract it. We've got several questions about asking about what should we do if we do get it and we have to go to the hospital? Are there any treatments that we should be avoiding? If a doctor wants to put us on a ventilator, should we instead insist on being in a hyperbaric chamber? Those kinds of questions. Should we go into the hospital or a doctor's office kind of armed with some specific information that's going to help us navigate that better?
Okay, first of all, let's talk about the whole ventilation thing, mechanical ventilators versus hyperbaric chambers. A hyperbaric chamber is an uncontrolled event. It's an uncontrolled phenomenon. I know them well. My residency program at Swedish Covenant Hospitals was one of the first 3 hospitals in the entire country. Harvard was one of the other ones to have a hyperbaric chamber being used. And the idea was to flood the system with high pressure oxygen, but it was for the purpose of healing wounds at that time, wound healing. We also saw that part of the reason wounds healed better was because it increased the capacity of the immune system. Okay, these are all facts. It's not a question, these are facts. However, that's different than mechanical ventilation. Mechanical ventilation is utilized to get a very specific pressure, and a very specific pace and timing, and a whole bunch of other little parameters for any given specific patient. This is a very individualized process. The pressures have got to be able to be adjusted very, very rapidly, very quickly. And so this is something that happens only with mechanical ventilators right now. There is no substitute for a mechanical ventilator, what it is you're trying to do. You're trying to bring in oxygen and exchange carbon dioxide, and this is what is really key. So if a doctor says you need to be on a mechanical ventilator, you need to be on a mechanical ventilator. There's no question about that. Okay. Now, what many of the ERs don't recognize is they don't quite necessarily understand why it is that many people still die on a ventilator, or why it takes them such a long time to do better. And ventilators are designed to move air to try to oxygenate. But if you have no iron, and here's what the COVID virus does, it separates iron from hemoglobin. And without iron in hemoglobin, and the hemoglobin molecule being intact, you can't get oxygen to stick onto the red blood cell. So if you don't have oxygen sticking onto the red blood cell, wherever that red blood cell goes in your tissues, whether it's the lungs or whether it's your muscles or your heart or wherever have you, there's no oxygen to be exchanged. And so your system starts to increase in carbon dioxide, it becomes more acidic. The more acidic it becomes, the more toxic it becomes. So you can push as much air as you want to, but if there's no hemoglobin tied to iron so that you can get oxygen to your tissues, that's why people fail on mechanical ventilators. It's the lack of iron, and here's the key. One of the regular laboratories that we look at, called the ferritin level, actually increases when you've got the COVID. So if you see a high ferritin level and low levels of what we call lymphocytes, that's highly characteristic of a COVID infection. Okay, and why is that? Because all the free iron is floating out there, not attached to the red blood cells. And so the storage form increases its concentration because you got all that iron out there. So you see lots of iron out where it shouldn't be. But remember, if you've got lots of iron out there, it means there's no iron helping you to carry your oxygen. Okay? So this is why mechanical ventilators are so important. It's because whatever you've got to be able to move that iron hemoglobin molecules as appropriately to the lungs so that you can get rid of the oxygen, whatever you got, and pick up the carbon dioxide and get it out of your system. Okay? So in my, once again, verbose fashion, the answer is very simple. Hyperbaric chambers are nowhere near closely related to being a substitute for a mechanical ventilator. Okay? Don't try to make that assumption. It's totally wrong.
And just to reiterate what you were saying just now as well, the first part of your answer there, if your doctor says you need it, then your doctor's probably got a good idea about it.
Remember, there are different aspects to the COVID presentation. Some people have the shortness of breath. Some people may experience chest pain. Some people will experience, a variety of other symptoms, including extreme fatigue. It is your doctor who recognizes which phase or which symptoms are correlating with what level of severity you've got with regard to the COVID. So don't sit there and try to challenge them on that, okay? They've got the information. They've got the 411. Listen to them. Okay, listen. They're trying to save your life.
We've got a couple of questions floating out here regarding just the course of the virus itself. We were talking a little bit before about herd immunity, and you had mentioned the idea that the flu season's going to come around and that's kind of when we expect to see the next spike. So we've got some questions that are asking, is this going to be like the flu where it goes away during the summer and comes back in the winter? And can we expect that after a year, 2 years, 3 years, whether we have a vaccine or not, that it's just going to kind of fade away?
We don't know. We have our anticipations. Look, once something shows up, you've got to anticipate that it's going to be around because viruses now replicate. Okay, that's what these things do. So now they're going to sit back, have seeds, and we don't know what their dormancy is going to be like or how this is all going to flow. But we strongly suggest we anticipate that, if this is what we call a psychrophile versus a thermophile. Psychrophiles are these viruses and agents that do better in cold temperatures, right? And most flus and flu viruses tend to do better in colder temperatures. If that's the case, then we should see a decrease over the course of the summer, okay? But then we anticipate an increase during the course of the winter. We don't know. This virus could be a thermophile or a hybrid between the two. Thermophiles do well in heat. Now, people have gotten the cold, they've gotten the flu in the midst of July in Chicagoland, where the temperature is like 16 billion degrees Fahrenheit, okay? It gets really hot sometimes, and people have been sick. So there are no 100%ers when it comes to this. We don't know, so we've got to be cautious. And again, remember, right now, we're at a point in time where the rural community is just now starting to come down with it, and we are approaching the summer months. So we're going to be basically watching and waiting to see how this creature moves. But at the same time, we're not going to just sit back and do nothing. This is why we're talking about all these powerful agents that we can use to help maximize our own immunity, to prevent or to minimize or to arm ourselves in the best way possible.
And we certainly are still seeing infections in Florida, in Southern California, and Arizona, in states that are pretty temperate throughout the year anyway. So obviously you can still get sick even in warm weather climates.
Absolutely. Absolutely.
So here's a question that I've gotten from a couple of folks related to the endurance of the virus. A lot of I'm wrestling with my own concerns because I've got a daughter who's college aged, and She's anxious to go back to school in August and resume her studies. And her university is kind of trying to figure out if they're going to do online schooling or if they're going to do on-campus schooling or some kind of combination of the two. And certainly I don't want my daughter to miss out on her college experience. And yet I have these concerns. And some of our other viewers are sending in questions asking about, if schools are saying, one viewer has specifically said, my family has a predisposition to copper toxicity and pyroluria, which are, as we've discussed in past webinars, those conditions could make you more susceptible to the COVID virus. And so she was asking, should we be explaining to our school districts we want to homeschool our kid because we have these conditions, these genetic conditions that would make us more susceptible to infection. How do we negotiate that? How do we explain to a school district that I've got this condition that maybe folks in mainstream medicine aren't really hip to, but that could very well make someone more susceptible to infection. And then again, and you always fuss at me for asking multi-layered questions, but I'll go ahead and ask the multi-layered question. Should I be scared about sending my daughter back to school, regardless of her biochemical makeup?
Okay, so those are all great questions, first of all. And for you folks who are asking the question, well, how do I explain to my university, my daughter's school, my son's school? You don't. They're not going to know what the heck pyrrole disorder is. Most doctors don't know what the heck pyrrole disorder is, let alone copper toxicity. They'll look at you like you're a nutball, okay? But what you can share is the idea that you have a condition that weakens the immune system. You can share that you got a condition that increases inflammation. And at this point in time, oxidative stress is a word that a lot of people have heard, even in traditional medicine. So you can say, yes, I've got markers that show I've got tremendous oxidative stress and makes me more susceptible or makes my child more susceptible to illness. And, there's huge inflammation present and my child's immunity is weakened as per testing, okay? And these tests are biochemical in nature. But the real deal is that you'll probably have to find an orthomolecular physician to write that letter for you, to write that note if you're that kind of concerned, realistically. We can kind of put it in terms where it satisfies the curiosity of the administration and at the same time gives credence to the condition that is laboratory tested and proven and is not someone's figment of an imagination, okay? Now, let's talk about school. Now, I don't know what schools are going to be doing for the fall. My partner's daughter-in-law is an educator, and I talked to her just yesterday, and I said, do you know what they're saying about school? She said, we've not heard a thing yet. We don't know. It's going to be a very tricky thing to navigate these waters at this particular point in time because we don't know how this COVID responds. It's going to be reacting in these months. And we're talking about putting together thousands of individuals into a confined area. I don't care if you've got a small campus, a medium campus, or a large campus. There's still dormitories. There's still, football games, all sorts of things that happen on college campuses in huge numbers of people. And I'm not sure that the school system has figured it out. I'm not trying to get into logistics. I'm not an educator directly with the school system. I think the safest thing to do would really be to look forward to online capacities for the next 6 months or so, at least. Okay. When school starts back up, it'll probably be safest to, if not implement that, at least have the option for people to choose online education versus going directly back into the classrooms and so forth. the last thing we want to do as parents is to get in the minivan, drive back to campus, unload all of that stuff for the dorms, and then 3 months later have to do the opposite. Usually we only do this 2 trips, right? Once to get our kids to college, and then once to get them back home at the end of the year. Here we'd be talking about maybe 4 times. That's not how the university system wants to work. So they're going to be very cautious, but we don't yet know what that outcome is going to be. Our recommendation is, better safe than sorry. We've already shown that there can be a system in play by which education can occur. It is not the prettiest, it's not the most fun, but you know what? It's the safest for now. Okay. So time will tell. We'll have to kind of walk that line as the dictum, as the word comes from the universities and their administrations.
You mentioned football games, and I just have to tell you that I'm a big sports fan, and I know that you are as well. We've had conversations about sports before. What do you think about what's going on with all of these professional leagues, the NBA kind of sequestering all of the teams and having them play out their season, but without fans in the arenas, and Major League Baseball talking about a reduced schedule, some of those schedules with fans, some without. What are your thoughts about that? Will we see sports resume in what we consider to be a normal fashion anytime soon?
I hate to say this because I'll probably get in trouble with all the Major League anything players out there. But Mr. Wells, I'd like to refer you to the Jetsons circa 1970s. And what they had going on were robots representing sports teams playing against each other in any given sport. And we laughed. We kind of said, now, how did that come about? Well, consider that right now, it would be much safer to have robots playing these sports. And I'm kind of adjusting here, but my real concern is for the players. Mm-hmm. Whether we have fans or not, the odds are we're not going to have fans at these events, but the players themselves, I can tell you statistically, somebody is not going to fare well. Out of all these players, all these teams coming across one another, we've seen people with hypertrophic cardiomyopathies just drop dead on the court, usually in high school basketball. Okay, one individual. But just as that one person can have a heart defect they don't know about, easily one person can have huge susceptibility to the COVID playing a professional sport and they don't know it. I'm much more cautious. Listen, I understand so-called life has got to go on, and you choose where your priorities are. You're talking to a physician whose priority is life. And from our perspectives, it is, you can't worry about life normalcy if you're not alive to begin with. Okay? And we've heard people say things like, well, I'm willing to take that risk, and I just want to have my normal life back. Well, I can tell you, this just may be practice for something that happens in our futures that is far more severe, where the vast majority of people will die. And I can tell you won't have your life going on as normal at that point in time. So we can practice a little bit more vigilance here and wait a few things out. It's tremendously stressful for everyone, but this is simply my perspective, okay? Not what the NBA or the Major League Baseball teams have got to say, or whatever have you. Yeah, we all want to get back out there and do what we're used to doing. And it may feel fine and normal, but all of a sudden we start to see lots of people dropping dead, or shall we say, ending up in the hospital more so. And our hospital system becomes overwhelmed again. Things are going to change again. So that's why we exercise caution. I don't have a definitive answer for you on that, because that's a very, very difficult question to answer with regard to what the administrators are going to do and what the seasons are. And, if players want to take that risk, that's up to them. And I'm sure many of them would rather just play knowing that there's only a minimal chance that this could happen to them. Okay. But that's something they're going to have to decide. And the Las Vegas bet makers are just going to have to wait. And you can still do your little, what's that thing called? Your imaginary brackets and stuff like that. Right. For sports. Right. Yeah, you can still do those, right?
Right.
But only time will tell at this point. Only time will tell.
Yeah, fantasy football takes on a whole new meaning.
Indeed, indeed.
Just a couple more questions that we have here. One that kind of harkens back to an earlier part of our conversation this afternoon, and that is related to other supplements that we can and should be taking to either strengthen our immune system or perhaps to help us once we do if we do contract coronavirus. One viewer is specifically asking about elderberry. We've seen some other folks ask about other supplements that are out there. Your thoughts specifically about elderberry, since that's the one that we've got, but what are some other natural things that we can find out there that might get us to some of the main 3 or 4 that you were talking about? You were talking about vitamin D before. Well, I spent some time, earlier today sitting out in the sun doing some work out in the sun, so I'm getting vitamin D from the sun.
No, you're not.
Okay, well that's my question.
Exactly. And what do I mean by that? First of all, let's talk about elderberry. It's a wonderful antioxidant. It's got great capacities, but it does not intervene directly in the pathway of this creature. Okay, it does not directly affect immunity. Listen, you can take 3 supplements, you can take 300. I've seen some lists that folks were taking that would curl my hair if I had any left. Okay, it can be too much and not strong enough to actually produce an effect. And each one of those bottles comes with a price tag. So some people are spending a few $1,000s every month on supplements that they really should not or don't have to. Okay, we talk about sort of the core supplements that you need, the core elements, and that's what we deal with. And they're really just 3 or 4, really. And everybody's got their perspective. And I don't want 50,000 people, sending us messages saying, well, what about this? And this has been proven that. No, we're talking about exactly what has been shown by statistical analysis and data, going everywhere from Wuhan, China, to Australia, to the rest of the world, as being directly involved in the pathogenesis, that is the problem-making capacity of the COVID. Okay, elderberry is not on that list. Neither is St. John's wort. Okay, and a few others. Now, don't get me wrong. You can take those if you want for other reasons, but I don't want people saying, well, this should be as effective as, and it is not. Okay, it's a wonderful, maybe 3rd, 4th layer adjunctive for general antioxidant capacity, maybe. Okay, but it doesn't wear the big S on the chest. Okay, it's not the super molecule that's needed right here, right now. St. John's wort, pretty much we just talk about it for depression. Okay, I've not even seen any studies. Now, I haven't seen it, doesn't mean they're not there. I haven't seen studies relevant to St. John's wort and the treatment of COVID. I don't think so. Okay, so those are some of the key parameters. People worry so much about supplementation. Clean up your diet. Okay, at this particular point in time, get away from the processed foods. That just creates inflammation all over your system. We talked to Samantha Gilbert, a clinical nutritionist, about that. We're sitting here trying to figure out, how to best support ourselves. And then we're going to go have, pizza tonight and burgers this afternoon and fries on top of that with a milkshake, because we can drive through our favorite location here, get that milkshake just handed to us. We don't even have to get out of our cars. Okay, get some exercise. These are all things that help to boost the immune system. Those are the supplementary pieces that we should use in addition to our key molecular treatment agents. Okay, so that's all I'll kind of say about that.
And what about the you said something kind of provocative when I said I'm outside in the sunlight, and you said you're not getting vitamin D.
Yes, for a variety of reasons, our ability to absorb vitamin D the way we used to has really changed. We really do not get as much vitamin A from being out in the sun the way we used to. First of all, most of us aren't even out in the sun the way we used to be. Okay, Before, we were out in the sun for hours and hours and hours. Well, I took a walk and I took Muffy out for a walk and we were out for a good 20 minutes. No, you did not accumulate enough vitamin D in 20 minutes time to do much of diddly, okay? How do we know this? Well, first of all, the average person, when we check vitamin D levels, their vitamin D is low, okay? Even in traditional medicine, mainstream medicine, not orthomolecular, mainstream medicine, when somebody's depressed, one of the first things we do is we check a vitamin D level. You sit down and say, well, it could be your thyroid, maybe try some vitamin D, that kind of a thing. Why are we saying that in general? Because most people are deficient and they don't know it. And they think because they've been out in the sun, they're getting a lot. They're not. Our bodies are no longer absorbing it the way we used to, okay?
The last question that's on our list here actually takes us back to one of the very first comments we made in this hour that we've been together, and that's talking about the protests. And one of our viewers is just asking, unrelated to COVID at all, but speaking to this protest, about the mechanics of I can't breathe, which is an interesting question given our current state. You know, asking about the idea of mentioning the fact that some folks are questioning whether or not someone who's pinned to the ground with a knee on their neck could get enough breath to actually say, I can't breathe. You know, what are the medical mechanics of that, of someone being able to speak even when they're saying they're not getting oxygen?
That's a great question, and I'm going to do something very unorthodox. I'm going to talk about not any particular religious figure, but I'm going to talk about the process of crucifixion, the ancient Roman process by which criminals were treated. And when they do that, they basically put you in a position whereby you literally have to pull down on your wrists and try to push yourself up in order to take a breath, okay? Eventually what happens is that you wear out and you can't do that anymore, and that's why you die, okay? As they put nails here, here, and here your feet, one on top of another, and a nail through there, your body has to be able to move in order to inspirate or get air, and then to exhale. And eventually your system tires out and you die. Keep that in mind. So now you have an individual lying flat on the ground, hands are tied behind their back, okay? And they've got not one person, but 4 people at different points on the body, putting pressure on the system so that it is very hard to take that breath, number one. Each one of these individuals more than likely weighs over 150 pounds in their 4. So that's about what, a minimum 600 pounds on this person's entire body, so that it's hard for them to move to get that air. That's just part one, okay? Now, I'm not the smallest fellow in the world, and I'm not the largest fellow in the world, but I can tell you, I would be hard pressed to have 600 pounds minimum on my body and be able to breathe, okay? For several minutes, not a few seconds, for several minutes. Now, part of that issue also is that there was a placement of a very heavy object and pressure on the neck here, as seen in the videos. So here we've got some major blood vessels. We've got carotid arteries, and we've got the jugular vein. When you have an object impeding or putting pressure at that point, what you're doing is you are doing what's called occlusion. You're stopping blood from being able to get to the head. You're stopping blood from moving between the head and the body, okay? So eventually, what's gonna happen is that someone's gonna pass out if you occlude those vessels long enough. Now, the mechanical side, somebody says, well, listen, if you can say I can't breathe, it means that you can breathe, okay? That's the mantra out there. But I want folks to consider the last breath. your ability declines over time as this pressure is put here. And at one point you can say, okay, I can't breathe. At another point, your capacity is diminished. Because remember, you've got many people, 4 people on your body and on your neck, stopping your ability to literally get a breath. Your hands are restricted. They're trying to stop you from moving. And now you can't gain any oxygen going to your head, okay? And then there is that other pressure of the mechanics of breathing, which you can't do either. So now you fatigue. Remember what I talked about with regard to crucifixion? Eventually you fatigue and you can't get that breath anymore. So maybe when this all first started, yes, you say, I can't breathe. That's my first warning, telling you I can't breathe, and then I'm done. Now, many of you folks out there have watched wrestling before, and the infamous sleeper hold that we saw with many of the wrestlers from back in the 1970s, right? What is that? At first, they put you in a position where they're basically occluding your blood vessels, okay? And then these guys are putting up a good fight for a good 35 seconds, 45 seconds, and the announcer is going crazy and saying, we don't know if he's gonna make it through this hold or not. Then the person usually just collapses if it's a good show over time, right? What does that mean? It means originally, he could fight a good fight, but eventually he peters out and he can no longer put up that fight and he goes unconscious. So what has happened, or what happens, is that even though somebody says at this moment, I can't breathe, eventually they're not going to be able to. Sheer mechanics and physiology says they're not going to be able to do so. So when someone is telling you something, hey, you know what, that's a big hint, because the next thing you know is, and they found this out, he was no longer responsive at one point, right? So what does that tell you? Something happened that was normal physiologic process that people are not paying attention to. That's how constrictors work, snakes, anacondas, okay? They coil themselves around you, they don't eat you. They crush you and they inhibit your capacity to breathe out. And then at the point where you can no longer breathe out, every time you take a breath, the constrictor tightens. And that's why I'm so leery of jungles and all those strange things, right? I don't want to ever encounter a python or a boa constrictor, because that's what they do. They basically suffocate you. And then when you're pretty much unconscious, then they start to eat you. Okay, but that constrictor mechanism is very similar to what we're talking about here. Okay, so we have to look at this a little bit differently.
Very good. Well, Doctor, that's all the questions that we have. No one else has sent in any questions today, and I think this is a good continuation of the questions that we started with Dr. Bowman a couple of weeks ago. Anything else that you want to add before we wrap things up today?
I do. We will be talking about this more so later, but I really have to both challenge and thank America. I'm not running for office. I have no political affiliations with any representatives, whether they're state, national, or citywide. But we've really come to see the heart of this country at many levels. Crisis exposes what lies underneath in individuals. And I have to say, the first people, believe it or not, I'm going to talk about is the police department. Look, we're viewing the challenges that are in the police department because they do need to have some corrections going on here. But folks, the vast majority of police individuals, police officers, are putting their lives out on the line, and they're really good people, and they do a really good job. It is a stressful job, and we've seen under this time a lot of stressful situations happen that need improvement. But to the officers who came by my neighborhood and parked their cars a few nights ago, I stopped and I thanked them. I don't know these guys. I just said thank you, because I and my daughter and my family would be able to sleep, okay, because of the potential threat of violence. And while this police officer and I were talking, I said, how are you doing? And he said to me, well, you know, we were just one neighborhood over, and a few nights ago we had rioting, and he said, I was hit by 20 different bottles during the course of that night. His heartbeat didn't rise a single bit, as far as I could tell. He was just sharing his story with me. And I said, I'm so grateful, really, for your sacrifice, for your putting your life on the line to help us. Okay. So I want to thank the police officers who are good ones in doing really their job. It's not easy, and they're often really clandestine. We don't know, they don't get recognition. Okay. Those folks out there who have, despite the risks, come out to share their displeasure and to voice the need for change and holding hands across all ethnic groups, I give great praise to you. You kids who are fighting now for change, I give great props to you, as you all would say. It's an amazing thing to recognize the need and to do something about it. But there are a couple of folks I also have to share in particular thanks with. First of all, in general, I want to thank the governors of the states of this great country and the mayors. You people have been working out some serious mess. It is not easy. You've got layers and layers and layers of crisis, and most of you are doing a great job. In the state of Illinois, I've got to give a big shout out to J.B. Pritzker, okay? And let me share with you, I went downstate to actually testify against something that J.B. Pritzker wanted to do, put in a new law with regard to something, I won't say what. And quite a few of us went down there, and I literally spoke in front of the subcommittee, and I said I did not like that. I was not happy with Mr. Pritzker at that point in time. But the job he has done during a time of crisis shows us who he is. And so to the governor of the state of Illinois, you are fabulous. I appreciate what you've done. Many of us are grateful for you and everything you've done and said at both a national and a local level. And please continue your awesome work. You're fabulous. To the mayor of Chicago, Lori Lightfoot, I gotta say this, Lori, you rock, okay? As the kids would say, you rock. The speech that you gave, talking about really uniting people here in Illinois and in the city of Chicago, everything you're doing, taking all the right steps, even discussing those things, it's just fabulous, fabulous, fabulous. And you two are not alone. This story is being repeated across many states and across many cities in the United States of America. And you've got so many governors coming together to try to solve a problem when we're lacking in many ways more global leadership, if you will, okay? Once again, I'm not here to get into politics, but I wanted to say thank you, because the citizens of America, the certainly local governments who know their people best, they're doing their best, folks. Please work with them. They're doing their best to take care of you. So I want to say big thanks to you. Keep up the good work. Let's persevere together. We can lick this thing. The wonderful thing about America is that Americans at our best, we can solve any crisis. We can solve anything. We've got to work together. Division is not the key here. So keep up your good work.
And if I can share something that you and I talked about earlier, but want to make sure that we share it with our viewers as well, and that is, while you're working together, keep wearing those masks, keep doing what we need to do to beat this pandemic crisis, in addition to beating this social discomfort crisis.
And that's one thing I forgot to mention. You're right, Mr. Wells. I was so proud of all these Americans out there, because while they were out protesting, many of them were wearing masks.
Yes.
And I looked at that, the majority were wearing masks. Now, maybe some didn't want to be recognized on video, but the vast majority were out there holding hands, wearing masks. And I thought that was just great. So keep up the good work, America. We'll get through this. We'll work together to get it done.
Absolutely, absolutely. Well, thank you, Dr. Mensah. Thanks to all of you for tuning in and being with us again today. Next week, we've got actually two important discussions to share with you. We're going to be meeting on Thursday at our normal time at 4 o'clock on Thursday, 4 o'clock Central on Thursday, with Dr. Michael Stevens, and considered by many people to be the leading expert or a leading expert in international psychology, and he'll be talking about culture.
The father international psychologist.
Yes, yes. He likes to be a little bit more
Humble.
humble about it. But Dr. Stevens will be joining us to talk about culture and context and how all of that relates to this COVID-19 pandemic. And then the next day on Friday at 4, we'll be speaking with psychologists from across the country to talk about just the collective mental health of our country. Dr. Brown down in Florida, Dr. Perez here in Illinois, Dr. Spalding in the state of Washington, all folks that have joined us in the past to talk about important issues. They'll be with us for a panel discussion to talk about the collective mental health of this country while we are wrestling with these multiple crises, the pandemic, the social unrest, and so on and so forth. So we encourage all of you to join us again on Thursday and Friday of next week for what will be a couple of very important conversations. Dr. Mensah, thank you as always. To our viewers, thank you for tuning in, and we will see you next week.
And Mr. Wells, if we do one more thing, let's continue to invite people to submit questions that they have.
Absolutely, absolutely. That
more
has
than happy to hand them in future sessions.
Yes, you're absolutely right. That has worked very well. So look for our video replay of this on social media. Look for our announcements of upcoming sessions on social media, and you can use those links that you see in social media on our Facebook page, on our YouTube channel, to send questions in advance to us, directly to me, and we'll make sure that they get included in the conversations that we're having. So again, thank you, Dr. Mensah. Thank you to all of our viewers, and we will speak with you soon.
Thank you, Mr. Wells.